and became what is a traditional now academic rheumatologist. Um, thought about parts of bodies, thought about inflammation, thought about immunology, all of which is fascinating and all of which has progressed beautifully during my time in medicine. But there's something that no one talked about, and that's the fact that patients actually leave the office and have to go back to become people. And they go back with the disease for which they were treated and the experience of the treatment. And very little had been done. And I knew nothing about that. And in fact, we were taught nothing about that. Um, and let's see if I can figure out how to do this. There are arrows here. I started to ask this question in the 70s. You have rheumatoid arthritis, or lupus, or what have you, and we're used to, all of us are well trained to ask all the relevant questions about inflammation and about organ system involvement. But I started to ask how's work, and I got what I didn't know how to cope with. So I have spent only 50 years trying to learn how to listen. By the way, I'm a believer in not only in medical education, but in medical education is too long, or 4 years is too long, or we ought to be recruiting every Doogie Howser we can find. I think it's actually a lifestyle to be a physician and a ministry to care for people who are sick. It is not a job. It is what I do. And housework is a major question for almost all of us. Now, when I ask that question, all of us think of, because we're trained to, and because this is the context of housework, what do you do? Where do you do it? And are you paid enough? That's a housework question. And I first came to the next line, which is an equation, when I was asked to address a national meeting of neurosurgeons at a time when neurosurgeons were whining a lot and complaining a lot. The reason was that they were about to lose their disability insurance. Neurosurgeons had maintenance of income insurance. Maintenance of income insurance means if you can't do neurosurgery, you get the same income. Sounds good. And neurosurgery was no fun because an awful lot of it was back pain, back surgery, and indemnifiable issues. We're going to talk much more about that in 15 minutes. And so the neurosurgical community was in trouble. They were not smiling. And when they asked me to talk to them, I said, hey, here's the secret to satisfaction of work. It's very simple. If you're not having any fun, you better be getting a lot of money. And if you're getting a lot of money, you can put up with less fun. And it actually works for rheumatology and life. It's part of what we think of when we think about how's work. The other thing is this question changed from how's work to how's working. Can you hear me? How am I doing? This has changed dramatically. This is a very different question now. The yellow line, the workplace has become abstract. Someone else has vision, someone else manages, someone else evaluates, and someone else decides. That's very different from what work used to be. And it still is. The most satisfied people in this country are self-employed. They work harder than anybody else and have a lot of anxiety about maintenance of work. But at the end of the day, they're much more likely to say this was a good day than people who are working in large organizations. And almost all of us are working in large organizations. So all of us are going through life under some set of issues that relate to our gainful employment. Um, we go through life with another set of issues that we don't talk about enough. And this is the classic study. I can show you many like this now. This was done by Lois Verbrugge in the early 80s. She recruited about 600 people, not patients, not workers, people from the suburbs of Detroit. She was at the University of Michigan at the time, and talked them all into keeping a diary. At the end of each day, they would put down every miserable thing that happened to them that day. And I can tell you, based on this study, that if any one of you goes 6 months without a backache, that's abnormal. If you go 2 years without shoulder pain, now I'm talking about something that you wrote down at the end of the day. Whether you went to the doctor, that's another question. It is all perfectly true that this is the basis for all the direct-to-consumer advertising that you see whenever you go near any television station. They know, not because they're bright, because they're lucky, that all of us have had to cope recently with something hurting. It may have been bowels. I can do this slide for bowel symptoms. I can do this slide for all sorts of symptoms, and it has been done. Surveys like this. All of us are having our sense of, I'm a well person, rattled a bit. Sometimes enough for you to call a doctor, sometimes enough to go to the doctor, sometimes enough to go to the pharmacy and take a pill or go to some alternative form of therapy that you find palliative. But it's like the workplace. There's a level of challenge that's part of life in the modern world. That wasn't part of life if you were self-employed, but it's part of life in the modern world. So that we all have this underlying sense of, am I well? How do I get reassurance? How do I cope with the next event? Is this the start of something? Will I have another one? Can I work despite this? And uh, when you study this, you learn that most of us have never stepped back to think about that. We just accept the fact that we can cope. And most of us do. And that's fine. That's one of the definitions of I'm a well person. It's not that I don't have symptoms, but if you go 85 years without symptoms, that's incredibly abnormal. If you go 85 days without important symptoms, that's to be expected. And the moment something happens, you've got to step back and say, I wonder if I'm okay. And most of the time you say, yeah, I'll deal with this. Now, the next component, because we're working our way up to what's going on in Washington and with most of your patients right now, the next component is this common sense thing. Common sense is not common and very seldom sense, but we all live with common sense. We all have words and notions that we keep and use and make it possible for us to understand the world as we see it. For example, all of you are able to hear somebody say, I injured my back. Now that's because they bent over, they didn't bend over, and it hurt. And all of a sudden they have a notion of a back injury. It's interesting. You wouldn't have a nose injury if you sneeze. This is all socially, if you sneeze or have a coryza or an upper respiratory, that's not an injury. Now, the fact that we can injure our back doing nothing unusual was invented. It was invented in about 1909. The initial invention was actually in this country, and it coincided with the invention of workers' compensation insurance, which was a disability insurance scheme that we all live with now, even though almost nobody in departments of medicine knows about it. It's a great big part of life in America and in every other advantaged country. It's an insurance program that says that if you have a personal injury that can occur in the course of employment, unexpected event, you can count on your insurance policy to pay for anything and everything medicine can do to put it right. and to make sure that your income isn't compromised while you recover. The initial workers' comp paradigm was because of major trauma. Nobody was thinking about backache when this was written. It was written in 1910 by Otto von Bismarck. And this is all about a social construction of disability. And the reason we can all talk about I injured my back is because we can, even though it's a sophism. The other part of our life that we inherited a century ago was best described by Weber, who invented the word bureaucracy. Bureaucracy also didn't come down from Mount Sinai on a tablet. It was invented as a description of the growing number of people that I just described before who help you make decisions and help you understand why your decisions are wrong. And all these folks who are not part of your immediate space in life, who are very much part of what that space looks like. And then I love the notion of wear and tear arthritis. That's another social construction. There is no such thing. Without trauma, we don't wear and tear. In fact, the best of the community studies that has looked at this is the Framingham study. Most of you have heard of the Framingham study because it brought us cholesterol. It also has a researcher named David Felsen, who's been studying for decades now, a cohort of people categorized by the degree of time they spend in tasks that involve mobility. And if you compare the people who have a lot of weight bearing in their life, this is not unusual life, this is people, with folks who are more sedentary. At the end of decades, if you look at their knees, the people who are more active have more cartilage. I can take you through other parts of the body, but wear and tear belongs in the trash can. In your mind, it's colors almost every time you hurt. But it's not true. We're really biologically excellent at healing, at repairing, at making things better. We're an interesting species. So what we're talking about are regional musculoskeletal disorders. You all have them. We all have them. We all have them repeatedly. We love to label them by the anatomical region and by our inference as to why we have them. And they come in epidemics. Epidemics. There's a list of them here. I'm going to spend a little time with a couple of them. How about railway spine? Railway spine was the scourge of Britain about 1920. It was such a big issue that Queen Victoria, because there was this newfangled thing called the passenger car in the railway, the common wisdom was that that's a dangerous thing to do, to sit in this is not to lay track or ballast or make trains or build bridges. This is sitting in the railway car. And that's dangerous because it shakes and rattles and bounces. And if it shakes and rattles and bounces, it's shaking and rattling and bouncing your spinal cord, which will get inflamed. And if you have an inflamed spinal cord, and by the way, the major theoretician for this was a Scandinavian surgeon named Ericsson. This was called Ericsson disease. And because of this, Queen Victoria would never allow her train to go more than about 10 miles an hour. She would creep along the railway in Britain all through that time. And Ericsson was pretty famous in Europe for describing railway spine. Fortunately, in Boston, we had a guy named Joe Mixter and Barr, and they were the potentates of spine disease at Massachusetts General, and they said baloney. So railway spine never crossed the pond. Down a little below that is RSI. Medicine has actually surpassed the Pentagon in acronyms. we seem to be wedded to, there's nothing that doesn't deserve an acronym. So you need a cell phone that translates acronyms. It's such a mistake. It's like the electronic health record. We've destroyed the narrative. We destroyed the beauty of the language. The descriptions are terrible. RSI is short for repetitive strain injury. And there was an epidemic of repetitive strain injury in Australia starting in the 80s. And it afflicted a particular worker. And that worker was doing data entry. And they was doing data entry for the government and for the banks. And Australia doesn't have 50 states, it has its states. And what was fascinating is in Victoria, this was destroying the workforce. Up around Brisbane, it didn't occur. The New Zealand world thought it was kind of a hysterical thing. They called it kangaroo paw. The Australians called it RSI, and it disabled a tremendous percentage of their workforce and slowed down the country entirely because data entry is that important. Back in the day, you couldn't get a bank statement without somebody entering the data. They actually went down to Australia for the WHO to look at this and studied it and wrote all about it. And it was sort of dangerous because there was a lot of union management anger over this. And studying it and saying, hey, if you really look at the role of context versus the content of the task, it makes no sense to call it a data entry injury. In fact, it makes no sense to call it an injury, since there really was nothing wrong with the wrist. So this was it's very hard to speak about these things without sounding like you're blaming the victim. I never blame the victim. I never point fingers at people. This is our minds capable of doing this, capable of having everybody at a bank say, oh my God, the data entry is killing my wrist. That one didn't cross to the States. We had our own. Each of these deserves a whole hour, and I'd be happy to give you a whole hour. Yes, many of you have tennis elbow, and you won't know about it if you don't have a backache. If you have a backhand stroke, you'll find out. And the secret is to run around your backhand. So I started studying these things to understand the role of the content of work, of tasks, and the role of the context of work, where you were working. I started with the RSI epidemics and antipodes, and then we had that happen in our country. We didn't call it RSI. We called it carpal tunnel. Now, when I was a medical student, I learned about carpal tunnel. It occupied probably about 5 minutes in one lecture in the second year, maybe 5 minutes. Now everybody has heard of carpal tunnel. Everybody wonders if they have it. And we're a pretty violent country. If you have carpal tunnel in this country, you have a scar in your wrist. That never happened in any other country. And again, each of these could be a full hour because we have a tremendous amount of data about that. The wrist story in America played out in the telephone industry. And the slides I'm going to show you I haven't used in a long time. We studied that. It turned out that this was a time when ATT, Ma Bell, was going to split up into US West. And what you're looking at are the three major components of Ma Bell after the division. The Supreme Court decided that was a monopoly and needed to be broken up. And what you're looking at is the number of cumulative trauma disorder cases, CTDs, that occurred in the late 80s in the various divisions of Ma Bell. And what you can see is it wasn't uniform. Now, most of these people are directory assistance operators. If you have no gray hair, you probably never had the pleasure of dialing 411 and getting a person on the other and said, "Can I help you?" And you say, "I want so-and-so's phone number in Washington, D.C." That was part of what was going on. This is when the people were being replaced with computers. That's the first thing that was going on. Uh, the second thing that was going on was something that didn't make sense. How damaging this was in some parts of the country and not others. Now, directory assistance operators were all based in one city, and we'll be looking at 3 of the cities for each of the states. And this was introduced at the time, this keyboard, by ergonomists. It's not a familiar keyboard because we all know the QWERTY keyboard, QWERTY on the top of your keys. These keys are arranged so that the stronger your finger, the more likely you are to hit the key. This was supposed to be a good thing. It's not easy to learn, but it's supposed to be a good thing. So some of the directory assistance operations had a new Dvorak keyboard, and some didn't. And everybody said, this is an evil machine. Now, if you complained of wrist pain in Denver, at the Denver Directory Assistance Office, this is what happened. You were treated by caring surgeons with a tremendous number of slicing. Carpal tunnel led it, but they had wrist releases. It's wonderful to read these records because I did. I went all through these records. So that there were 72 people out of a small workforce in the Denver Directory Assistance Operators who had surgery and months of rehab. There were far fewer in Phoenix. So people said it must be the keyboard, but it turns out it has nothing to do with the keyboard. In spite of a national scream about this, the national scream, this is Communication Workers of America, was that being a directory assistance operator was an intolerably dangerous job and that the employers were at fault. And here's what you can see in the different cities. This tremendous difference of the ability of the medical community to do surgery and the ability of the worker to let it be done. You know, if you go to a doctor and the doctor says to you, geez, I've got a good idea about why your arm is hurting, and I've got this procedure and I'm going to sew your right earlobe to your left earlobe and turn it around your belly button. And in my experience, because I've had a lot of experience, this works most of the time. Almost every one of you would say, I'm out of Dodge. Because people know better and patients know better. But these are neither. These are claimants. So the next take-home lesson forever is if you have to prove that you're sick, because lots of folks are trying to tell these people, hey, it didn't hurt in Salt Lake City and it hurts here. There's something wrong with you. What kind of wuss are you? If you have to prove you're ill, you can't possibly get better. And that's one of the many lessons that we need to take into the current climate here in Washington. The government got involved in the CDD epidemic. They sent a group from NIOSH to investigate all this and looked at the workers in Phoenix, Minneapolis, and Denver, the directory assistance workers. They were looking for CTDs, cumulative trauma disorders. That's a neologism. It makes absolutely no sense, but everybody thought it was sensible. And it was defined that working with that keyboard represents a traumatogen. So it's a dangerous trauma. And if you get repeatedly traumatized by your traumatogen, you will have injuries affecting your wrist and hand. So this is the formal definition that they went about. Now, if you have a presupposition like that, and go looking for it in a multivariate system like people, you'll find it. But they couldn't find it. They looked real hard. They said, look at where these people are hurting. Some are in the hands, some are in the wrist, some are in the neck. And here's what's going on, they said. It's amazing that they did this. These are not dumb people. These are people working with preconceived notions on large data sets and finding what their preconception was. And then they did associations. Now, I want you to not read this, but look at this, because this kind of slide is in every journal every week. This is going into a large data set looking for associations. This is called garbage. It's the garbage out from the garbage in. There's absolutely no way you can tell what association happened by chance. You can say it should be improbable, but I've been arguing for a journal titled The Journal of Irrelevant Associations. It's very easy to do these. And if you have a question that you're asking and you're going into a large data set like this, you'll get your answer. In fact, the way we talk about it is you can torture that kind of data long enough until it says what you want it to say. So they found a whole bunch of these associations. What's interesting is there was very little that was ergonomically reparable. But what was really impressive was the psychosocial associations. Almost all of the people who were hurting didn't like the context of work. It wasn't the context of work. And it's not easy to work in a place where you hate going every day, which is basically what NIOSH concluded. That last one, we can recommend redesigning the work, but realize that we can't find anything that would guide us in the redesign, because almost all of this, and that's what was going on. The communication workers thing was anger. There was anger all over the what used to be Mabel. And by the way, it still exists. Those of you who go to a hairdresser, there's a good chance that hairdresser has a scar on his wrist, because this was supposed to be a dangerous profession for carpal tunnel. And the surgeons should know better, but they go to great lengths not to. We're fine. This was my introduction. Here's where I wanted to go, and I needed to prepare you to go there. You all know about Framingham because it gets talked about all the time. Framingham is the study that solidified the notion of cholesterol as a risk factor, including some really elegant work on why it should be. And it is true, if you don't have an extraordinary family history and you have a high cholesterol, particularly if you're a man, you're probably putting, in terms of all-cause mortality, about 3 months at risk. And it isn't clear that the statins reduce that. In fact, it's pretty clear they don't for primary prevention. If you've had a heart attack, it's a different discussion. But all this screening stuff in perfectly well people is based on that kind of data. There are other data sets in addition to Framingham, and I'm going to show you two that are exceedingly important. This is the Whitehall. Whitehall is the euphemistic name for the British bureaucracy. It's enormous. Brits like bureaucrats and they like lots of government employees. We're getting there too. And the Whitehall cohort studies were started, maybe 30 years ago. And they've been following the British bureaucracy for decades. And the original design of the study was the same thing as Framingham. Cardiovascular risks and cardiovascular events and outcomes, and the same business about cholesterol and smoking. Smoking, they all show. And BMI, which is now an acronym that has a short half-life, which is sort of your gut-butt ratio. BMI is about to go the way of cholesterol. In fact, those people who are pudgy live longer, not morbidly obese and not too skinny, but pudgy's okay, which makes me very happy. So pass the chocolate pudding. There, that was no reason to do the Whitehall study. The reason they did the Whitehall study was to look at other things that might compromise all-cause mortality, might compromise your longevity. And the original observation was the higher you were in the civil service rank, the longer you lived. And they thought that was going to turn out to be diet, minimal diet. There's something else. And when they set the study up, they came up with these associations. The people who were least satisfied at work, the people who thought there was something that was unjust about their workplace, the people who thought the pace of work was intolerable, social support, control, and conflict, all of those variables. That's what correlated with two things. One was short-term absence from work for back pain. Now, think about that. Why would that be? And the answer has to be something like, it doesn't cause back pain when you have these operant variables. But if you go to work hating it and you have a backache, your back will hurt worse. Not because you're a wuss, but because you're a human being. When things are going well, it's a lot easier to ignore something like that. If you can, sometimes you can't. The other thing the Whitehall study showed, now, all of us have days when we're unsatisfied with life at work and where we think it's unjust and where we think there's not enough support and we don't have any control. But when that becomes your lifestyle, you're going to die sooner. In fact, if you answer my question, how's work, and say to me, it's awful, that's about the same risk level as smoking in terms of all-cause mortality. And then something happened very interesting when Maggie Thatcher was prime minister. Maggie Thatcher was one of the very few people who really liked talking to Ronald Reagan. And Ronald Reagan liked talking to an economist named Hayek, who got a Nobel Prize, who is the one who really invented downsizing and outsourcing. And the British economy was a little rough, and their budget was a little stressed when Maggie Thatcher was prime minister. So she said, hey, I've got all of these tens of thousands of government employees. Why don't we cut a bunch of them out? So she got her advisors to look at who these people were, the people who were the numbers on her printout. And she said, hey, we've got this thing called the PSA, which is the buildings and grounds. And there are a lot of people who work in buildings and grounds. In London, Whitehall is based in London. And she said, why don't we just give that task to a private company and get rid of these people? So here's this Whitehall study where they know everything you could possibly know about this cohort, this subset of the bureaucracy, because you've been following them for 20 years. The person responsible for this is Michael Morbid, an absolutely lovely man, Sir Michael, mind you. And he is an OBE. And it seemed to make sense. And I guess from an economic business point of view, it made sense. You take them off the public roll, they're not responsible for their pensions, their disability claim, their insurance, their anything, and just pay some company to hire them back at whatever rate. Now, we all know what downsizing means. Downsizing means that half of the population will be unemployed and the other half will be employed doing the same task at half the salary. That's the definition of downsizing from a cynic like me. from an economic viewpoint, it frees up money for other pots. So they did that. And the health of the downsized population went to hell in a handbasket. The divorces went sky high, alcoholism went sky high, smoking went sky high, and lots of pain appeared in that population. And they started to die early. That's the Whitehall cohort through the PSA. That's kind of annoying or unsettling or sad. But there's another cohort study that's even more. Comes from Finland. The Finns have a really wonderful tradition in epidemiology. At 10 unpronounceable cities, and I've tried, at 10 unpronounceable, there has been a group of epidemiologists following the municipal workers for a very long time. And then, all of a sudden, the Finnish economy got in trouble because of border wars with Russia. And they looked at the towns that had records that were online and discovered that there were 22,000 employees. And those towns, some of them, not all of them, had to downsize because of the downturn in the economy. And it's like the Whitehall study. Here's this population that's being followed for a decade. Everything you could possibly measure has been measured. And all of a sudden, they're told everything that you know is about to disappear in the pillars of your existence, including your income. Now, both Whitehall and the Finnish 10-town study are occurring in countries that have national health insurance schemes. In our country, you lose your job, you lose your health insurance. In Britain and in Finland, that's not the issue. So that variable is not part of what's going on. This is simply, who am I now that I don't have a job and don't have access to one? And what happened, it's actually fascinating. The number of workers in the towns claiming they injured their back skyrocketed. They went off work as workers' comp claimants. And any money that could have been sequestered by the government from downsizing went to the other pot, paying for workers' comp premiums. So there was no net gain to the government, in spite of this dramatic change in the life of tens of thousands of people who were employed. The other thing that happened in Finland is they started to die ahead of their time. Their all-cause mortality is a very telling, very interesting, unequivocal outcome measure. We don't talk about that. You know, in our country, you can't die without a diagnosis. I wrote an editorial in JAMA about 10 years ago called The Ripe Old Age, in which I told what I was doing. I was signing out frail elderly patients who died on my service with the diagnosis, it was her time. And I kept getting phone calls from Raleigh. They said, Dr. Hadler, you can't do that. And I said, I sure can. I just did. They said, no, we need to be able to categorize the cause of death. And they said, no, it was her time. And I said, I'll tell you what, there are at least 5 to 6 diseases in this frail elderly person vying to be the reaper. I'll give you the list of disease, you pick. This actually is what's wrong with a lot of the advertising that masquerades as science on death rates. These are all contrived. Most of the time when the elderly die, we're not sure which of the diseases they had was the last one. It's so the 10-town study had all-cause mortality. They didn't deal with just cardiovascular. It didn't matter. Dead is dead. But when they looked at case-specific cardiovascular mortality, it went up too. So it was not just people who were dying, It was some of the people were dying from heart disease. I like this slide. It's got pretty colors. I designed it near the ocean years ago. It's nice to have a single slide that captures only 50 years of my work in this area. It's everything I've been telling you. So you as a person, not as a patient, not as a worker, you as a person are going to be coping with something that really is disturbing to you. Since I'm a rheumatologist and since it tends to be the label most commonly in this universe that we're talking about, it tends to be a musculoskeletal symptom that I work on. But it didn't have to be. It could have been headache, could have been bowels. Colleagues of mine at Carolina, we've got a big GI group, and they're fascinated with bowel habits. So they were following the UNC student body as to their bowel habits. Now, you can't get into Carolina if you have a pimple. It is the world of the prettiest people, absolutely the prettiest people. And what they discover is at any given point in time, about 10 to 20% of the undergrads would qualify for irritable bowel syndrome had they been foolish enough to go up the hill to the medical center. But they didn't think that was a problem. They were squirting and tooting because it was exam time or they were fighting with their significant whatever. It comes and it goes. But just like I told you, I can medicalize all of you on musculoskeletal symptoms. I can medicalize all of you on bowel symptoms. I can do it with other things too, like rashes and pimples, and it's called medicalization. These are predicaments of life. And predicaments of life is a term that came to me in the middle of the night many years ago. We're the only language that has the word predicament. It's a word that is not value laden. If I say you have, it's not good, it's not bad, you didn't do something, nobody did something to you, it's a predicament. And so you will have predicaments. They're normal. They're no fun. Some of them are really no fun, and some of them will lay you down for a while. But they are predicaments. And you have to do something. You can't do nothing. Doing nothing is an option. That's called persist in coping. That's the staying a person going down to the left. And it's not lonely. I mean, there are direct-to-consumer advertisements for everything, from people who are willing to squeeze you, pull you, yank you, press on you, talk to you. All sorts of things are out there. You just have to pick in the menu that that seems most rational to you. And fortunately, you'll probably be rewarded with a regression in your predicament. Not always, and we have lots of data on how to make that predicament less resistant, more likely to persist. Diagnosis will do it. Nobody gets a diagnosis without a workup, and nobody gets a workup today. It's scheduled over time. And believe it or not, nobody deals with a medical diagnosis without doing it on their own. The chief complaint is, I've got this bowel symptom, this whatever it is, and I've been reading everything. I can't figure it out. And I'm somebody who doesn't complain. That's not a wuss. That's a person with a predicament. And there's nothing wrong with that. What's wrong with that is the context when they come near us. We don't understand that. I've been waiting for 50 years for a patient to walk into my office and say, hey, doc, I feel like crap. Could it be in my mind? To which I would say, gee, I hope so. Sure beats leukemia and inflammatory bowel. That's really good. And if it's in your mind, we'll see if we can figure out with some help how to get you back to coping with your predicament without going for 5 minutes 5 months of diagnostic evaluation, at the end of which you are no longer the same person. And you want to know something? We can spot this most of the time, right at the beginning. And the worst thing we can do is to give you an acronym. I call them acronomias. To call you POTS, I have no idea where that one came from. To call you fibromyalgia, there's nothing wrong with your fibro. I don't know what these words mean. What we mean is, I really hear you. This is a miserable experience. And it's the kind of experience that you probably coped with last year. And it's highly unlikely because we know from follow-ups. By the way, Mayo Clinic has taken some of the acronomias and followed them for decades. And nobody develops lupus or RA or multiple sclerosis or all these other words that hang like an imprecation over the society. You can seek medical care, and hopefully you've got a well-trained physician who's willing to listen to you, which is why I hate artificial intelligence in the clinic. It only works well for artificial patients. I think the electronic health record is an abomination. It's only good if you're an orthopedic surgeon because the template has one plank for right or left. But my patients, maybe it's me, or maybe the really complicated patients go to Duke. I think that's true. I get the straightforward ones. But it's not what medicine is about. Most of medicine lives in the history and the interaction and the trust. That's why we went into medicine. We wanted to be a safe port in a life that always has storms, hopefully predicaments, but may not be predicaments. May be the start of one of these things that you have reason to be concerned about. It may be your presentation of leukemia. But we can figure that one out pretty quickly. I just want you to get through that diagnostic experience. No worse off for it. And then there's this third limb, seeking care in the context of the workplace. And this is, for a guy who started out as a physical chemist, I've moved a long way. If you want to understand this, read Kafka. I kid you not, read the trial. The trial is about a banker who is accused of a crime and ends up, number one, going before the courts, and number two, going crazy because they never told him what his crime was and he couldn't figure it out. So I don't want to victimize. I don't want us to teach medical students how to victimize. I want us to be able to talk to people in a way that doesn't accentuate their illness. And it can be done. It just requires a little bit of time, maybe a lot of time, and a little bit of trust, maybe a lot of trust. And those two things are covariates. So this becoming a claimant, which is an industry in this country, an industry. The SSI is up in Baltimore with 25,000 adjudicators. 5 to 8% of salaries pay for workers' comp. It's all hidden. I wrote the paper on the first slide in 1985. I think it's the only paper in the Annals of Internal Medicine on workers' comp. And I was really proud of it. I was spending a lot of time. These are papers that don't write themselves. You've got to think about every word. And my son came home from graduate school, and I said to him on my word processor, is this paper I've been, it's true I was on the editorial board of the Annals, which is why I knew it was going to be published, and which is why I wanted it to say exactly what I want to say. It was called The Internist and the Injured Worker. And the argument was that one of the ways to a self-satisfying life is through gainful employment. In our culture, that matters. And I said that a lot of what you've heard, that there are lots of things going after you, so that you need to have energy invested in having a good life with gainful employment. And my son chuckled. He said, only a doctor would write that. This was 30 years ago. He said, because only a doctor could go through life imagining how difficult employment is for most people. So he introduced me to a literature called the Literature on Peasant Resistance. A wonderful particular scientist named, who just died, Jim Scott, who studied it around the world. He said, it's hard for a doctor to imagine that going to work would put a knot in their stomach. And that was probably true in the 80s. It's not true now. It's really sad how hard it's become to practice medicine according to your conscience. It's really hard that we're allowing people to think that the solution is in turning patients into numbers and doctors into providers. And I can tell you that is not the solution. I promised Ray this quote. Last year, I gave a keynote speech at Duke Divinity School, where the topic was scientific evidence, and I talked about it, the worldview of St. Augustine versus Buber. Very different worldviews, very different ways to look at very different ways to socially construct words like happiness and caring about each other. So I'll leave you with Buber, which is much closer to the medical solution. He was not a physician. Maimonides was, but that's another quote. Man wishes to be confirmed in his being by man and wishes to have a presence in the being of the other. Secretly and bashfully, he watches for a yes, which allows him to be and which can come only from one human person to another. So of all the thoughts I've left you with, from the notion of having to prove your will, this is the last thought that I want you to keep.